All right, guys, welcome back to Underground Science. In this video, we'll be talking about autoimmune lymphoproliferative syndrome. Okay, so let's go and get started. All right, so before we talk about this, right, we should know that this syndrome is associated with defective peripheral tolerance. Okay, but what is peripheral tolerance? So remember, we talked about central tolerance already in our previous videos. Okay, for example, when we talked about things like autoimmune polyglandular syndrome. But peripheral tolerance is basically the same, it has the same goal, right? It has the same goal as in not wanting your self tissues to get destroyed, right? And that's why peripheral tolerance is there. So in case you have certain cells, like T cells, for example, that have escaped central tolerance, right? Self-reactive T cells that escape central tolerance, and then now it's in your circulation, right? So you have peripheral tolerance mechanisms in order for that self-reactive T cell to not start attacking your own tissues. Okay, so let's say, for example, right? Let's say you have some tissue turnover. Okay, not damage, just normal tissue turnover. Okay, your macrophages, of course, can phagocytosis and present it onto MHC2, which is a self-antigen now because it's your own tissue debris that it phagocytosed. And let's say you have a self-reactive T cell that escapes central tolerance from your thymus and is just in your circulation now. And that self-reactive T cell can bind and recognize the self-antigen. However, there's no damage, no trauma, no infection, no inflammation, none of that, right? No damage associated molecular patterns, okay? No damage associated molecular patterns, and no pathogen associated molecular patterns, okay? So no DAMPs and PAMPs, all right? So if there's no damage to the cell, right, no trauma, so there's no damage associated molecular patterns, right? If your own cell tissue gets damaged or undergoes trauma or destruction, right, things from inside the cell can leak out. Like what? Like certain damage associated molecular patterns include heat shock proteins, right? Heat shock proteins, ATP, right? Certain DNA fragments can also leak out if you have trauma or destruction of your tissues, right? And so on. So, but there's none of that, right? It's just normal tissue turnover. Now, if there was an infection, let's say, from a bacteria, right? Let's say, then you would have certain pathogen associated molecular patterns, right? For example, if this was some sort of, for example, if this was like salmonella, right? Then you would have flagellin, right? That would activate your toll-like receptors, specifically toll-like receptor 5. If you had something like a gram-negative bacteria, right, we would see lipopolysaccharides. That would be also another example of pathogen-associated molecular patterns that can activate your antigen-presenting cells like your macrophages and dendritic cells, right? So pathogen-associated molecular patterns like those that's seen in infection is not present here because there's normal tissue turnover. So what I mean by this is that DAMPs and PAMPs, if those were present, then along with the presentation of self-antigen, your antigen presenting cell, because your antigen presenting cell, due to the presence of DAMPs and PAMPs, would get activated and upregulate B7. Okay, so let's go and write that down. So remember, we have normal tissue turnover, right? But there's no inflammation, no infection, no tissue trauma, etc. So if there's no inflammation or infection, right? There's no infection, so we have no pathogen-associated molecular patterns. Like what? Like, for example, like lipopolysaccharides, right? Or like flagellin, for example, that you see in multiple bacteria, right? Like Salmonella, like Pseudomonas, like E. coli, Listeria, Vibrio cholera, Helicobacter pylori, right? Things, pathogens like that. But we don't see any of that, right? We don't see any pathogen-associated molecular patterns because there's no infection. And then there's no tissue trauma, so you don't see any damage associated molecular patterns. So that means if there's none of these, then the antigen presenting cell does not get activated enough to upregulate and put B7 on its surface. Why is B7 important? Because the T cell has CD28 that binds to B7. If this interaction occurs, remember, this activates the T cell. And we don't want that because it's a self-reactive T cell. But if there's no B7, right, and if this interaction occurs, right, but the T cell doesn't get activated, this self-reactive T cell does not get activated because there is no B7, because no infection or inflammation or trauma. If that happens, so no B7 CD28 interaction, then what happens is this T cell undergoes anergy because you need this co-stimulation of B7 CD28 for the self-reactive B cell T cell, sorry, self-reactive T cell to get activated. If you don't have the B7 CD28 interaction, the T cell gets inactivated, or also called anergy, right? It undergoes anergy. If this happens repeatedly, what I mean, if this interaction, right, between an antigen presenting cell and a self-reactive T cell happens repeatedly without any inflammation or infection or trauma, which means what? No B7 will get put onto the surface of the antigen presenting cell, then that means repeated interactions. So if repeated interactions like these happen with no B7 and no CD28 interaction, then the self-reactive T cell undergoes apoptosis. Okay, if repeated interactions like this happens with no B7 and CD28 interaction due to no infection, inflammation, or trauma, right? Then apoptosis will occur through the Fas and Fas ligand pathway, right? So what I mean is, so let's actually write that down right here. So if repeated interactions happen, what happens is other T cells nearby, right, also have Fas. Okay, so let's say this is a T cell nearby, and let's say this is a self-reactive T cell in this example, right? And let's say this is the self-reactive T cell that has undergone repeated interactions, right? In which it hasn't got activated because there is no B7 and CD28 interaction because there's no infection, no inflammation, or no trauma. So then that means that this self-reactive T cell needs to undergo apoptosis, right? So what happens is this T cell, right, the self-reactive T cell has Fas on it or CD95. So it's a Fas receptor. And another T cell nearby can have Fas ligand, right? And if this T cell binds to the self-reactive T cell, we're going to have a signaling pathway, activation of caspase, right? Remember caspase, and then this will lead to apoptosis and destruction of our self-reactive T cell, which is good because we don't want it attacking our own tissues. But what happens in autoimmune lymphoproliferative syndrome is we have a mutation in this pathway, okay? So we'll talk about in the next slide. So let's just go through this right now. So another important part of peripheral tolerance is our regulatory T cells. Okay. Remember, our regulatory T cells, what do? They actually recognize our self antigens and they have a lot of abilities, right? So, something cool about regulatory T cells, and we'll talk about these T cells more when we talk about IPEX syndrome, is they have CTLA4 on them, okay? A molecule called CTLA4. And what CTLA4 does is it actually binds to B7 on antigen presenting cells and it binds with a higher affinity than CD28 can bind to B7. So if CTLA4 binds to B7, then that means B7 can't bind CD28, right? On T cells. So that means T cells, right? In this case, self-reactive cannot get activated, right? Cannot get activated. So that's one way where regulatory T cells induce peripheral tolerance, right? They bind to B7 at at a greater affinity than they can bind to CD28 as CD28, right? So CTLA4 binds to B7 with a greater affinity as compared to CD28, binding to B7. This leads to no interaction between B7 and CD28 because CD28 can't bind now, right, to B7 because of CTLA4 is the one binding to B7. If CD28 and B7 doesn't happen, right, if that interaction doesn't happen, we know that's really important for activating T cells. So in this case, if this was a self-reactive T cell, then the self-reactive T cell would not get activated, right? Because no CD28 and B7 interaction would occur due to CTLA4 binding B7. So that's one way. Another way is these T regulatory T cells or these T regulatory T cells, right, can release IL-10 and TGF beta. Now remember, IL-10 decreases activity of Th1 subtype. So the Th1 subtype for CD4 helper T cells. What did Th1 subtype do? What's one of the cytokines it released? Remember, it released interleukin 2. What was interleukin 2 really good for? Activating CD8 T cells. So in a way, right, because IL-10 reduces the activation and the overall activity of Th1, that will lead to eventual decrease in activation of CD8 T cells. So it's another way to decrease activation of your immune system, right? That's what regulatory T cells do. Another thing IL-10 will do, it actually reduces MHC2 expression, right? So if you reduce MHC2 expression on your antigen-presenting cells, then you reduce the activation of T cells, right? Because T cells bind to MHC2 and then they get activated. Okay, so that's another function of our regulatory T cells, okay, which again is really important when it comes to peripheral tolerance. All right. So that was another job of what? Interleukin 10. All right. And then another thing that interleukin 10 can do when we're talking about regulatory T cells is it reduces cytokine production. Okay. So inhibits cytokine production, which again will reduce inflammation overall, right? Okay, so that was interleukin 10. Now, regulatory T cells can also release transforming growth factor beta or TGF beta. What does TGF beta do? Well, TGF beta, right, suppresses macrophages, activation of macrophages. It suppresses activation of dendritic cells, and TGF beta reduces T cell proliferation, okay, inhibits T cell proliferation. And on top of that, TGF beta also can um, increase the count or increase differentiation, I should say, of regulatory T cells, right? So increase differentiation of regulatory T cells. So you get more, helps increase the count of regulatory T cells, okay? Transforming growth factor beta does. So as you can see, the cytokines and along with CTLA4, right, that are released by regulatory T cells, what at the end goal of these molecules is to inhibit the immune system, right? So you don't have autoimmunity. So that's why regulatory T cells are a vital component of peripheral tolerance. Another fun thing to know is that that regulatory T cells can also release perforins and granzymes, just like we're familiar with CD8 cells, right? Cytotoxic T cells, which can also kill our self-reactive T cells, right? So if it sees the self-reactive T cell, it can release perforins, and then it can release granzymes, and then that can lead to the destruction of our self-reactive T cell. So again, as we can see, regulatory T cells are really important in basically inhibiting autoimmunity. Okay, as a which is that's why these cells play an important role in peripheral tolerance. And as we said before, repeated exposure to self-antigen without the expression of B7 and CD28 will lead to T cell apoptosis due to the Fas and Fas ligand pathway. Okay, so let's see what we have now. So as we were saying, we're really like honing in on the Fas and Fas ligand pathway and caspases. The reason for this is because in autoimmune lymphoproliferative syndrome, you have mutations in the Fas gene, or you may have mutations either in the Fas gene or the Fas or mutations in Fas ligand or caspase 10. All of these, whether that's the Fas receptor, right, or the Fas ligand, or the caspase enzymes, all of these are important for inducing apoptosis in these self-reactive T cells. So if you have a mutation in any one of these, you can no longer undergo apoptosis, right, of your self-reactive T cells. So that means your self-reactive T cells just won't die. So they're going to keep on proliferating and accumulating. And that's what will lead to autoimmune lymphoproliferative syndrome. Okay. Lymphoproliferative syndrome. Okay. So let's see that. So let's say we have this T cell right here. This is the self-reactive T cell, and it needs to undergo apoptosis. So another T cell nearby has Fas ligand on it. This T cell has CD95 or Fas receptor on it, right? And if the Fas ligand binds, then this cell will go under apoptosis because you have once Fas ligand binds Fas, we know it activates caspases, and caspases leads to apoptosis. But if this is defective due to mutations in the Fas or mutations in the Fas ligand or mutations in caspase 10, right? One of the caspase enzymes, any one of those three spots, then apoptosis cannot occur, right? So that's what's defective in autoimmune lymphoproliferative syndrome. So if you can't undergo apoptosis, if these self-reactive T cells cannot undergo apoptosis, we're going to accumulate these cells. This is going to lead to the accumulation and proliferation of these self-reactive T lymphocytes. Okay, so that's not good at all. So let's see what findings we can find based on this, based on the accumulation of self-reactive T cells. If these self-reactive T cells never die, they're going to accumulate and proliferate, right? And they will never die. So one of the spots that these self-reactive T cells can deposit into is our lymph nodes, which will make our lymph nodes bigger, which is lymphadenopathy, right? So you have these self-reactive T cells that can accumulate in your lymph nodes, making your lymph nodes bigger, which is called lymphadenopathy. These T cells, these self-reactive T cells that accumulate can also deposit in your liver and spleen, leading to hepatosplenomegaly. Okay, so hopefully those findings make sense. Now remember, T cells are really important for activating B cells. What happens is if you have this excessive accumulation and proliferation of these self-reactive T cells because they're not dying anymore, right? Then these T cells can activate self-reactive B cells. Because remember, your B cells also undergo tolerance mechanisms like central tolerance, for example, and peripheral tolerance. But if you have self-reactive B cells, right, then what happens is all of this, all of the accumulation of all of these self-reactive T cells can start activating self-reactive B cells. So your self-reactive T cells, right, you have a lot of them now because of the mutations that we talked about in the Fas ligand caspase pathway. And you have a lot of these now. And remember, T cells are the one that activate B cells. So B cells can class switch and produce antibodies like IgG, IgE, IgA, IgM, and whatnot. If you have a lot of these self-reactive T cells, it can activate self-reactive B cells, right? Self-reactive B cells. And maybe these B cells, right, are self-react, and these B cells are self-reactive against red blood cells, white blood cells, and neutrophils, for example, right? And platelets. So let's see how this works, right? So let's say you have a self-reactive B cell that also escaped central tolerance in the bone marrow, right? Self-reactive B cell here. So what happens is, remember, they have surface antibodies that act as B cell receptors. So let's say this is an IgD antibody, right? Or immunoglobulin D, which is an antibody. And this is our BCR, B cell receptor. And like if we use the example of red blood cells, right? Let's say there's certain red blood cells that are damaged, okay, or lysed, and it releases antigens. Like for example, like band 3, right? Band 3 or Rh antigen or whatever, right? So let's say this is some sort of antigen from the red blood cell. If we have self-reactive B cells, these self-reactive B cells, right, can bind onto this RBC antigen. We'll just say RBC antigen, right? Red blood cell antigen. So if that happens, right? So let's draw our self-reactive B cell with its IgD and our RBC antigen bound here. What it can do is our B cells can also internalize antigens, right, as we know, and present them on MHC2. So it's going to internalize this antigen, okay, and it's going to cut it up into small peptides and present it on MHC2. So if we have our um, MHC2 like that, let's say, right, and then we're going to have peptides that are part of the antigen, and then we're going to present it, right? So remember, in order to for B cells to get activated and produce antibodies and class switch, it needs to interact with T cells. So let's say we have a self-reactive T cell that also escapes central tolerance in the thymus gland. It's going to have its T cell receptor, right? That's going to bind to our self antigen, in this case, our RBC antigen, red blood cell antigen. But remember, we need a second signal in order for these T cells to completely get activated. So the T cells, remember, have CD40 ligand, right? And then our B cells will have CD40. This interaction has to occur in order for our T cells to get activated. So when this occurs, our T cells get activated and secrete like interleukins, like interleukin 4 and interleukin 5, which we should well know now. We should know well that these interleukins stimulate class switching and the activation of our B cells, right? In terms of secreting antibodies. Like what, right? Like we secrete IgG, IgE, IgA, and so on, right? Due to class switching. So now we're secreting all these antibodies, but what are these antibodies targeting? Our red blood cell antigen, right? Because this is our self-reactive B cell right here. So, so now all these antibodies are targeting our red blood cell antigen. So if we go back to our findings, right, we can see certain autoimmune features. Why? Because we have self-reactive T cells, and if those self-reactive T cells activate self-reactive B cells, in our example, we said that those self-reactive B cells are going to make antibodies against our red blood cells, right? Then that's how that's going to occur. The same mechanism we talked about, right? So it should make sense now, like why in this autoimmune lymphoproliferative syndrome, we can see things like autoimmune hemolytic anemia, because we can get antibody production against our RBCs, our red blood cells, which can lead to the destruction of our red blood cells, leading to anemia, right? Hemolytic anemia specifically, because we're destroying our red blood cells. So that's that mechanism. Same mechanism, right? Which can lead to antibodies against our platelets, which is called immune thrombocytopenic purpura. Why is it why is it thrombocytopenic? Because if you make antibodies against your platelets, so let's say you have your antibody platelet complex like this whole thing can go to your spleen and get destroyed. So you're destroying your platelets, which means you're going to have low platelet count, which is what thrombocytopenia means, right? So that's what's called immune thrombocytopenic, and then purpura because you see lesions, right? Or things like bruising, right? Bruising, so things like ecchymosis, petechiae, and purpura. We see those things when we talk about low platelet count, right? So that's why it's called immune thrombocytopenic purpura because it's autoimmune. You see thrombocytopenia due to destruction of the platelets in the spleen, and due to that, you see bleeding, and one of those being purpura. Okay, so that's so you can make antibodies against your red blood cells, platelets, neutrophils, right, which lead to neutropenia, which is low neutrophil count. Okay, and so you can find those, right? So cytopenias basically is the main autoimmune feature, right? So you can see cytopenias in this disorder due to abnormal activation of your self-reactive B cells, which are activated by your self-reactive T cells. And of course, if these T cells don't die, right, because of the mutation, the Fas ligand and caspase pathway, then it'll keep on accumulating and proliferating and accumulating and proliferating, and then you have and the more that happens, more mutations can accumulate, and the more you increase, right, the chance of getting lymphoma, right? So that should make sense too. All right, so that's basically autoimmune lymphoproliferative syndrome, right? Um, so something else that we can talk about is that in this syndrome, you can see something that's important, right, in terms of diagnosis. So a different type of um, T cell, right? Normally, T cells are what? They have either CD4 or CD8, right? So if they're CD4, we call them CD4 positive cells, right? And if they're CD8, we call them CD8 positive cells. So CD8 positive cells are cytotoxic T cells, and CD4 cells are helper T cells. But remember, we also have CD3, right? That are part of our T cells too. That's why we call it the T cell receptor complex. So here's what I mean, right? So in this syndrome, though, what you can see is something called double negative T cells. Okay, so you still have CD3, right? You still have that CD3, but you'll see no CD4 and no CD8. So that's why it's called double negative T cells. Okay, so this is double negative T cells. So you may see this in autoimmune lymphoproliferative syndrome. Okay, and something else important that we should know is that you can also see so something weird, right? Is you can in the labs you could see increased vitamin B12, okay, in this syndrome. And the reason for that is not because, this person's consuming a lot of vitamin B12 or absorbing a lot of vitamin B12. It's due to the reason that all of the accumulation of all these T cells, right? These self-reactive T cells, your immune cells, like your granulocytes, right? So your neutrophils, basophils, eosinophils, right? And these T cells, these self-reactive T cells that are accumulating, they can release haptocorin. So remember, when B12 gets absorbed in your gut and goes into your bloodstream, then it binds transcobalamin, right? It binds transcobalamin, specifically 2, right? So it binds transcobalamin 2. And remember, transcobalamin can then take it to various places where B12 is needed, right? So remember B12, for example, B12 is needed to make red blood cells, and B12 can also be stored in your liver too, right? But there's another approach. So if you measure B12 in labs, right? B12 is either bound to transcobalamin 2 or bound to transcobalamin 1. Transcobalamin 2, though, right, is the bioactive form because it actually delivers it to your tissues so you can use B12, right, in your tissues. But the other form in which this test is measuring B12, right? If you do labs for B12, you're measuring the amount of B12 bound to transcobalamin 2, and you're measuring the amount of B12 bound to transcobalamin 1. Transcobalamin 1 is also called haptocorin. Most of the B12 is bound to transcobalamin 1, which is the storage form and not bioavailable. So the reason why you see increased B12 levels is because, like we said, granulocytes and these self-reactive lymphocytes that are just accumulating and proliferating and not dying can release transcobalamin 1, or also called haptocorin. So that means if you have a lot more haptocorin, you have a lot more B12 binding to haptocorin, which can falsely say that, which can falsely tell you in the blood test, right, that you have elevated B12 levels. Even though you don't actually have more bioavailable B12, it's just showing elevated B12 due to the fact that these immune cells can release haptocorin, which will bind more B12, which can show as elevated B12 when you do labs. Okay. So that's just important finding. And of course, if you're secreting antibodies against cells that your bone marrow makes, then you can also see a hypercellular bone marrow. Okay, a hypercellular marrow. Because remember, you're making antibodies against your red blood cells. You're destroying those. You're destroying your platelets, neutrophils, things like that. So your bone marrow is going to try to obviously compensate and make more of those because it's getting destroyed. So you may see a hypercellular marrow also in the syndrome, which is important to keep in mind. Okay, and we'll talk about this more when we talk about hemolytic anemia, specifically autoimmune hemolytic anemia. But you can do the Coombs test, which basically tests for antibodies against red blood cells. And of course, if we have antibodies against red blood cells, which we do have in autoimmune hemolytic anemia, the Coombs test would be positive. Okay. And we'll talk about this more when we talk about autoimmune hemolytic anemia in a separate video. Okay. Now let's quickly talk about the treatment. Okay. So it makes sense that one of the treatments is corticosteroids, right? Because this is autoimmunity and excessive activation of the immune system and autoantibody production. And we know steroids reduce all that, right? Reduce inflammation, inhibit your immune system. So this is important, right? And then let's fix that, just circle, right? So corticosteroids is one, then rapamycin, right? What does rapamycin do? It inhibits the mTOR pathway, okay? Remember, the mTOR pathway is really important for cell growth, proliferation, and survival, right? But we don't want these self-reactive T cells to continue to grow, proliferate, and survive. So if you give rapamycin, that can inhibit mTOR in these self-reactive T cells, which will block the proliferation and survival of these self-reactive T cells. So that's what rapamycin does. Okay, inhibits the mTOR pathway. And then of course another option can be a hematopoietic stem cell transplant. Okay, so I hope this video helped. I hope it wasn't too confusing. Thank you guys for watching and see you guys in my future videos.